And finally, we have a patient perspective. It's my pleasure to introduce Thelma Brown. She's a 14-year breast cancer survivor and a cancer research advocate. She serves as an advocate for multiple organizations, including the TBCRC, NCI, Bio Task Force, as well as the University of Alabama Breast Cancer Working Group. She's also a Komen Scholar and member of the Susan G. Komen Advocates in Science Steering Committee. Her particular interest is in health equity and increasing minority participation in clinical trials. It's my pleasure to introduce Thelma Brown, who will be reviewing Bringing Trials to All Patients, a Patient's Perspective.
Thank you, and thank you to the organizers for understanding the importance of bringing the patient's voice into these conversations. My slide is not it. Okay. Now it's going too far. Before I get started, I would like to just read this quote from Martin Luther King. "We are caught in an inescapable network of mutuality, tied to a single garment of destiny. What affects one directly affects us all indirectly." Now, I think this is very important when we start talking about inclusion in clinical trials. It is not just about that one patient being able to access a clinical trial. It's about everybody. And everybody being able to access a clinical trial will ultimately move the science forward. And that is what it's all about. It is about moving the science forward. It is about bringing patients into the fold. It is about advancing health equity. And this is the first step of it, including patients in clinical trials. I'm messing up today. Okay. Maybe I'm on track now. Sorry about that. So what do we know? We know a lot about it already. We know that substantial investments have already been made in breast cancer research. And we know that we've seen great progress from those advances. However, we also know that everybody has not benefited from those advances. We know that the participation in clinical trials overall are woefully down. I mean, people are just not participating in clinical trials across the board as we would like. And we also know that they're just not readily accessible to everybody. And that's a problem. It's a problem for the patients, and it's a problem for the science. Let me see if I get this right this time. There we go. Inclusion is very important. We need for all patients to benefit. That's just plain and simple. Also, that genomic data that's gathered from those clinical trials, in the era of big data, this is where we will see some advances in the science. We will gain new knowledge through this genomic data. But if everybody is not adequately represented, then that data will be flawed. It will be missing something. So it's important to include everybody. And the clinical trials need to reflect the general population. We don't know how efficacious these drugs will be across the board. We don't know the toxicities of the drugs across the board. If everybody's not included in the clinical trials, we will have to wait on those post-marketing studies. And how many people will be harmed or that drug is not effective if we have to wait until then? That's why it's so important to have everybody involved on the front end in the clinical trial process. And again, it affects the generalizability of the results, plain and simple. So who is left out? I'm going to just highlight some of the groups that are left out. This is by no means meant to mean that the groups that I highlight, that's all inclusive. Couldn't do that in 15 minutes time. But I am going to highlight a few other groups that are woefully underrepresented in clinical trials. We know that Black women are 40% more likely to die of breast cancer. We know that Black women present at a later stage. We're diagnosed at an earlier age. These disparities make it very important that Black women are included in clinical trials. However, we represent only 3% participation in clinical trials, and that's a problem. So when I was preparing for this talk, I reached out to women and asked the question simply about, what do you know about clinical trials and would you participate? And a 40-year-old Black woman living in Nashville, Tennessee, gave me this quote. I didn't know about clinical trial, I didn't know what a clinical trial was. My cancer came back, it just kept spreading, nothing was working. My doctor didn't know what else to do, so he sent me to another doctor. I wanted to try to live for my babies. So I did a trial, and I'm getting better. That was a last resort for her. Should not have been. So very often we wait and use clinical trials as a last resort, but that shouldn't be. But we do know that there are some things that are considered barriers to participating in clinical trials. One of those is the lack of clinical trial education. As this young lady said, she had no idea what a clinical trial was. Now, I can get on a soapbox about education, and as Dr. Hirschman mentioned about education as related to compliance, patient education across the cancer continuum is important. Imagine if you were dropped in in a foreign country, not knowing the culture, not knowing the language, and you were expected to thrive. Well, that's what we're doing to cancer patients. We're just dropping them in. No context no knowledge about the cancer system. We're just dropping them in and expecting them to either sink or swim. So clinical trial education is very important. And like I said, I could talk forever about the importance of education because it means a lot to me. But I think that's the very first step. We have to do a better job. Access to care is a barrier. Most people get their cancer care in the community settings, which they don't have the infrastructure, they don't do the necessary referrals to the comprehensive cancer centers, so access to care is a barrier. System, provider, and provider mistrust, or we could rephrase it and say a lack of trustworthiness. However you put it, it is a problem. Physician unconscious bias. Very often physicians are not just asking. I was at a wonderful program yesterday where there were 4 different organizations that did surveys, and it came up over and over again that for whatever reason, the physicians were simply not asking. Eligibility criteria. There are a lot of comorbidities associated in the African American and Black community, and very often they will serve as an exclusion to participate in clinical trials. And in the age of targeted treatment, biomarker testing has become very important. And unfortunately, there is a disparity in biomarker testing. And those biomarker testing serves as the gateway into participating in a lot of clinical trials. I'm going to look for just a moment at the Hispanic and Latinx communities. Now, I recognize that the Hispanic and Latinx community is a very heterogeneous community. And so when I speak of that, I'm speaking in this term, I'm speaking in a very broad sense, recognizing that there's a lot of differences in that community. Again, the Latinx community, there are disparities in diagnosis. The mortality rate is higher, and it is the leading cause of death in Hispanic and Latinx women. Again, I asked a number of women in this community the same questions about your knowledge of clinical trials in which you participate. And a 52-year-old Mexican-American living in Linwood, California, answered this like this: I became educated about clinical trials because of a Facebook group. I knew nothing about it. Before that, I knew nothing and would not consider participating. Even though there's a lot I still don't understand, I would consider it. This information did not come from her doctor. It came from a social media group. But that tells you the power of the education, that now she would consider it. And the barriers are very in line with the barriers associated with the African American community. The lack of clinical trial awareness and education, disparities in biomarker, low socioeconomic status, access. The language barrier is a big barrier in this community, mainly because our protocols are so complex. It's hard for anybody to understand. Again, we're plopped down in this foreign country. But you add to this another layer of that language barrier, then it becomes almost impossible for certain populations to feel comfortable that they know enough to sign that informed consent to even being a part of a clinical trial. So language and communication barriers are very a big deal in this community. And we look at the rural population. People in the rural population are less likely to get cancer, get breast cancer, than people living in urban settings. However, they are more likely to die. A SWOG study showed that when given the same care as someone living in an urban setting, their outcomes were the same. Again, the same question was asked. And an African American metastatic woman from North Carolina answered the question: my community has very limited knowledge about clinical trials, and if they were educated, they still don't have access. So you see a common thread emerging. These are people from different communities, but some of the same barriers are across the board. Limited access to clinical trials. In the rural settings, they may have to drive much further because those trials are in urban area in the big academic settings. Lack of knowledge, transportation, and financial considerations. Imagine driving a couple of hours each way and then spending time at the cancer center. That time off from work, along with those extra dollars spent, that presents a barrier. Again, distrust and fear, physician bias. One study showed that physicians were not encouraging people in rural areas to even think about clinical trials because they themselves saw that their location was a barrier, and there was just no reason to even ask. So not asking is showing up over and over again. Clinical trials in the elderly population. Well, breast cancer is a disease of the aging, right? And so we don't really know how these drugs are affecting the elderly people, or because they're just not being included in clinical trials. And our population continues to age, which means that the cancer burden will only increase, which means that it is even more important that we get this information and data from the elderly population. I asked a caregiver this time about clinical trials because I knew her mother had dealt with breast cancer several times, and this is what I was told. My mother was diagnosed at age 72 with metastatic breast cancer after having early stage breast cancer more than 20 years earlier. I asked about clinical trials, and I was told she was too old. End of discussion. That's what she was told. Well, elderly population have some unique barriers, and that's one of them is that narrow eligibility criteria. Those comorbidities, in addition to the comorbidities, the elderly people tend to be on more medications. And so that is seen as a reason to exclude. But in my mind, that's even more reason to include, because we need to know what would be the interactions with these oncology drugs with the drugs that the elderly people are taking as our population ages. Again, there are physician-driven barriers. Physicians are just not asking older people to participate. But if they are asked and they're eligible, elderly people participate at the same rate of everyone else. But again, those other barriers prevent them from even being in the conversation. Financial considerations, of course, again, that education and awareness. Caregiver influence cannot be overlooked in this population because very often elderly people rely on other people for their transportation, to help with their decision making. So we must consider when we talk to elderly patients or talk about including elderly patients, it's not just them. Of course, all other populations have their family members, but in the elderly population, their family members and their caregivers are even more important to be included in this conversation. Men in breast cancer trials. Well, that has been a long-standing problem. Men are just not included. Men are treated with the drugs that were designed for women, and we don't have good trials on how drugs will be effective, if we can have drugs that will be targeted just for men. Those trials are not done, mainly because it's a small population, and drug companies don't want to invest what it takes, the number of people would take to accrue. But if we have 10 men dying from the disease, we need some information about it, and the only way we'll get the proper information is through clinical trials. And I spoke with a white man, age 47, de novo metastatic breast cancer, as male breast cancer almost always is de novo. And he said a lady with metastatic breast cancer was on a trial and suggested that I look for a trial. I found nothing. That's not surprising to anyone. And those are the barriers. They're just not available trials. And many are excluded on the basis of their sex alone. Now, the FDA has come out with new recommendations that says you should not exclude men on the basis of sex alone, but it's just a recommendation. So we'll see how that translates into increasing the accrual of men in breast cancer. We are where we are. However we got here. What matters is where we go next. Of course, history matters. We learn from the past, but we're right here. So we need to move forward. And I say we need a call to action. Everything that I have said here, nothing is new. We've heard it over and over again. We are aware of all of the barriers. You hear it and you see it in the literature, and if you have not, all you need is a quick Google search. Awareness means nothing without a moral imperative. It is morally the right thing to do. It is ethically the right thing to do. It is scientifically the right thing to do, and it's clinically the right thing to do, to increase participation of all in clinical trials. It's the right thing to do. We need a new model. This model that we have, quite frankly, is not sufficient. It has not served the patients well. We need to start over. If we're serious about advancing the science, we can only advance it if we have everybody in this fold. We talk about that common thread. The new model should include improved access, clinical trial education, and that bias training. I say a step further from the bias training. Training alone is not going to get us out of this. We need strategies in place that, because we all come with bias, and even when we come with bias, we need some strategies in place that can run offense or defense. I'm not a football person, so excuse me if I use the wrong term. But we need a strategy in place to counteract those implicit biases. If it means a system where you all have to do some kind of checklist. Could be something low-tech. But something needs to be put in place that will go around those biases. We need to make all those barriers, to address all those barriers a priority. If it means telehealth, if it means financial considerations, whatever barrier that we noticed, and as we saw, they were coming along all those different populations. And if they're coming along those populations, even the people that are adequately represented in the trials, they have some of those problems too. So addressing those barriers will impact everyone. Develop patient-centric, and I like to use human-centric trials. And the reason I use that term is that we come into the institution as a patient. We may stay there 4 hours through our infusion, and we go home, and we're still a human. We're still a person. So the trials need to address our needs as a person and not just as a patient. Value the patient voice. We're the experts in this disease. We need a seat at the table when these trials are being designed because we know more about the different populations, and our experience, our lived experiences as patients, as navigating this foreign country that we call cancer land. So we need all of that in this new model. We cannot do this without our stakeholders. This is a big ask. We've been doing this so long, and change is not comfortable, but change is necessary. And we cannot do it without our stakeholders, and every stakeholder has a role to play. And that role does not mean staying in those silos. That role may mean reaching across the aisle to collaborate, to share best practices, what has worked here. We need the sites to look at what barriers does my particular site pose. We need our funding organizations to be willing to add additional funds when we start designing clinical trials, be it for PROs or extra funding for those out-of-pocket costs that causes financial toxicity, which is a big issue across the board in cancer care, but sometimes can be more pronounced in clinical trials. But every one of our stakeholders can do something. And we're gonna need it if we intend to make a difference. Each one of us can make a difference, but together, we can make a change. And so, there used to be a session at SABCS that something about what we're gonna do on Monday morning. I can't remember the exact topic, but I ask you, whatever the capacity you are here at SABCS, I know you have a vested interest in this, otherwise you wouldn't be here. But whatever capacity that you have, I ask that you examine what can you do on a personal level to change the discourse, to change the story, to rewrite the story of participation in clinical trials. What can you do on Monday morning? We need you. Our lives are depending on this. We can't do it without you. Thank you.
Thank you so much, Ms. Perry Brown, for the powerful presentation and powerful message. We have time for one question. Microphone.
Hey, Thelma. So it's not really a question, it's a challenge to all of you oncologists and researchers in the room. If you think one advocate is good on your trial, 5 from diverse backgrounds are better. If you want black people enrolled, have a black advocate. Even better, have a black investigator. If you want Latinx people, have a Latinx advocate. Have a gay advocate, have a man. Together, as Thelma said, we are stronger. And if you involve us in every aspect of clinical trial design, we can help you enroll patients faster, better, and get the drugs that are going to save our lives to us faster. Thank you.
Yeah, on that wonderful note, we'll close the session. Thank you so much for attending today.